This session is clinical therapies for exudative AMD, diabetic macular edema, retinal vascular diseases, and inflammation. So I'd like to thank my co-moderators, Nico Iannuzzi and Basil Williams, my colleagues from Bascom Palmer, and all the panelists who have stayed on in spite of our delays and have made time for us. We're very appreciative of your time and thankful for your commitment to the program. So without further ado, we'll start off with Anat Lowenstein, who will be speaking to us about longitudinal validation and real-world management of home OCT and neovascular AMD.
Hello, I'm Anat Lowenstein, and I would like to thank the organizers for inviting me to participate in this meeting, Angiogenesis 2026, and to present our longitudinal validation and real-world management studies with home OCT neovascular macular degeneration. These are my financial disclosures. In this presentation, I will show the study comparing the longitudinal performance of AI and home OCT with expert human graders. I will show the first ever real-world case of home OCT-based disease management, and I will reflect on the path bringing this novel technology from idea to clinical care. The home OCT gives us highly granular longitudinal information that is not available through sparsely sampled acquisition made during office visits. The longitudinal data trajectory of the total retinal hyperreflective spaces volume gives valuable insights into disease dynamics and treatment response. The question for this study is if a human expert looking at a series of OCT images would come to the same clinical conclusion as that made through AI analyzed data. In the two studies that led to the FDA approval, we learned the following. First, it was demonstrated that images acquired via home OCT and in-office are equivalent in regard to visualization of key biomarkers, as you see in report number 1. In addition, it was shown that the estimation of key biomarkers in individual images using AI agreed significantly with that of expert graders as presented in report number 2. The next question to ask is if a human grader looking at a series of images will have the same review for presence of change, which is agreeing with that determined through AI-based analysis. And I'm going to describe this study now. Home OCT data from 180 patients was used. The series of images collected over 5 weeks by the patients were analyzed as follows. They were reviewed by 3 experts for the presence of changes to generate a reference data set, and then images were processed through AI-generated home OCT trajectory. A personalized change detector called reference change value method, as well as global threshold-based detection was used. The outcome measures were area under the curve of the receiver operating curve, ROC, demonstrating the trade-off between false positive and negatives. The sensitivity and specificity of the RCV method were also recorded. This method is a method that allows for detection of changes in the hyperreflective space trajectory of patients in a personalized fashion. We use what is called the reference change value, RCV method, which is adopted from laboratory medicine. The idea is as follows. We feed the trajectory to a predefined function. The signal is defined as the difference between the maximum and the minimum. The noise is defined as the variation around the fit, and the signal to noise ratio is calculated as ratio of the signal to noise. When the SNR level crosses a certain threshold, it is defined as significant. By using this SNR-based score rather than fixed thresholds, we ensure the detection accounts for inherent biomarker variation that we know that exists in each individual from our clinical knowledge. Here we can see an example of a noisy trajectory that automatically is set to a higher threshold, while a more stable trajectory is set to a lower threshold. And the question is if such personalization in change detection perform better when compared with human graders. A total of 296 5-week trajectory were analyzed by expert graders. 107 were marked as having changes, and the others as stable. The AI analyzed data marked change versus no change using either a personalized or population threshold, and the error under the curve with the personalized was 0.98, and that with population-based approach was 0.97. The sensitivity was 99 and 94 with the personalized and population-based approaches respectively, while almost the same specificity was recorded of 89.4. This shows us that there is a strong correlation between the AI-based change detection for either approach. The personalized approach works better, but the population one is also in a good agreement. And the use of AI is really important for real-world application. And on that note, I would like to show you a patient which was treated according to the home OCT findings. So as you know, like with a new treatment, when you try with a new technology, we always use it first on patients who are difficult to treat. Like this patient with 69-year-old lady, we looked at her left eye with CNV, courtesy of the Wanger Kapoor Institute. She presents with subretinal fluid. The previous interval of 50 days is treated with faricimab. The interval is reduced to 42 days. Again, presents with subretinal fluid, treated with faricimab. Interval reduced to 35 days. Now she returns without fluid and maintains a similar interval. Now she would like an extension and hence is switched to aflibercept 8 milligram. However, again presents with fluid and the interval is switched back to 33 days with no fluid presence. So whatever we did to the patient, she remained with the 33 to 35 days interval. And now she was switched to the home OCT, and she starts nearly daily monitoring, and then the AI-powered notification decides when she goes to the office for treatment. As you can see here, the process continues. She's repeatedly treated at very safe intervals according to the threshold, and that now she was able to stretch for 41 to 45 days, even though she's a very, very hard to treat patient. And here you can see a full view how she's over a year. It's not that the home OCT is doing any magic that all of a sudden she responds, she can be extended more. It is just that it gives more granular data so we know exactly how to treat them and kind of a safety net that comforts both the physician and the patient. Just gives us very, very good results. Now she is continuing monitoring. Visual remained at 20/30 as she started 14 months ago, and the patient is very happy. This is the evolution of the technology. First, it was just a device that the patient could use by himself. And also later on, the AI-powered data analysis came upon, and now it's ready for clinical use. Of course, you need to show the validity of this treatment, and we did tests for over 2,000 patients. You can see here the outlined squares here are for the pivotal trials that led to the FDA approval. So to sum up, with a large prospective trial that showed that the home OCT provides comparable visualization to in-office OCT, and that the AI estimation of the hyperreflective spaces volume matches that of human graders. And the retrospective study that I presented here showed the longitudinal clinical decision between expert graders and home OCT plus AI-based are also comparable, particularly when you use a personalized notification threshold. And early cases show the validity and clinical utility of the home OCT in the management of our patients with neovascular macular degeneration. Thank you for your attention.
Great talk, Dr. Lowenstein. I think it seems to me that patients would like this. It's easier to do it at home, all other things being equal. But is it going to save the healthcare system enough money to make it economically feasible to have these in people's homes?
I think what you're saying now is a very crucial issue because, the technology is there, the science is there. Now what is left is the integration with the health systems. And this is actually what's happening now following the FDA approval and the reimbursement agreements. I think this is what remains to actually be I wouldn't say validated, but worked out. Exactly. Thank you for
Okay.
Great.
Great. Okay, well, let's go on to the next talk from Mark Barakat, who's going to be talking about machine learning-based volumetric analysis of neovascular AMD biomarkers in Tenaya and Lucerne. Thanks, Mark.
Hello, this is Mark Barakat from Retinal Macular Institute of Arizona here in Scottsdale, AZ, talking about machine learning-based volumetric analysis of neovascular AMD biomarkers in Tenaya and Lucerne. Here are my disclosures. I'm delighted to present the first of 4 faricimab presentations in this session. Later, you will hear from Carl Danzig, who will share results from Avenel X long-term extension study, Viral Chef, who will present the latest Voyager study results, and finally, Jemmy Cheng, who will discuss 1-year results from the Salvine trial. In this presentation, I will focus on examining several biomarkers to better understand the importance of Ang2 inhibition in the proven clinical benefits of faricimab in the treatment of AMD. This slide illustrates the main drivers in each of the Ang2 and VEGF-A pathways involved in retinal vascular disease. As shown, elevated VEGF is mainly involved in driving neovascularization and vascular leakage in retinal vascular diseases, while elevated Ang2 is mainly involved in driving vascular leakage, inflammation, and fibrosis. In the following slides, I will discuss clinical biomarker targets for dual Ang2 VEGF-A pathway inhibition by presenting outcomes from the Tenaya Lucerne phase 3 trials of faricimab. The specific biomarkers that I will cover are retinal fluid, PED, and subretinal hyperreflective material, with a particular focus on machine learning-based quantitative analysis of PED and SHRM. Firstly, we'll examine retinal fluid. Prior work analyzing the Tenaya and Lucerne trials showed that faricimab resulted in better anatomic improvements than aflibercept 2 mg in the head-to-head dosing phase, when patients in both arms received 3 treatments in the first 12 weeks, so injections every 4 weeks. Specifically, as shown on this slide, faricimab resulted in a greater reduction in CST from baseline compared with aflibercept 2 mg from week 4 through week 12. In addition, the proportion of patients with no SRF and IRF was also higher with faricimab compared with aflibercept 2 mg from week 4 through week 12. Next, we examine changes in PED. As we know, PED is common in neovascular AMD, with reports indicating that up to 80% of patients with neovascular AMD have PED. Notably, PED is more difficult to resolve than IRF and SRF in eyes with AMD, as indicated by the requirement for consistent anti-VEGF therapy and recurrence during PRN treatment. As shown here, and consistent with retinal fluid findings, faricimab resulted in a greater decrease in maximum PED thickness throughout the head-to-head dosing phase compared with aflibercept 2 mg in Tenaya and Lucerne patients with a baseline PED height of 125 microns or greater. On the right side of the slide are OCT images from a faricimab-treated patient demonstrating an approximate 50% decrease from baseline in PED thickness at week 12. Given these findings, we examined if dual Ang2 VEGF-A inhibition with faricimab also reduces PED volume versus aflibercept 2 mg. To do this, we use automated quantification of PED volumes with a machine learning retinal OCT segmentation algorithm, or ROSA for short. This algorithm was trained using Spectralis SD-OCT images from multiple trials, including Tenaya and Lucerne. ROSA PED volume annotation has excellent correlation with human annotation, as indicated by an R-squared of 0.99 and a DICE score of 0.87. For this analysis, we used ROSA to evaluate PED volume in a 3 mm diameter ETDRS subfield in patients from Tenaya and Lucerne who had baseline Spectralis SD-OCT images. As an example, here on the slide is a regular OCT image with clear PED and the same image with ROSA segmentation of PED volume. As can be seen on the slide, faricimab resulted in a greater decrease in PED volume at weeks 8 and 12 in the head-to-head dosing phase compared with aflibercept 2 mg in patients with any PED volume at baseline. These findings corroborate the PED thickness analysis findings. Similarly, in patients with high PED volume at baseline, which was defined as a baseline PED volume greater than the median PED volume of the overall population of approximately 243 nanoliters, faricimab resulted in a greater decrease in PED volume at weeks 4, 8, and 12 in the head-to-head dosing phase compared with aflibercept 2 mg. On the right-hand side of the slide, we have OCT images with ROSA segmentation of PED volume showing a decrease from 754 nanoliters at baseline to 191 at week 12 following treatment with faricimab. Next, we examine changes in SHRM volume. SHRM is an area of disorganized subretinal tissue linked to the development of subretinal fibrosis and is indicative of more advanced disease. Of note, SHRM is associated with worse vision before the start of treatment, while resolution of SHRM is associated with better vision outcomes. We examined if dual Ang-2 VEGF-A inhibition with faricimab reduces SHRM volume and en-face area versus aflibercept 2 mg. The evaluation of SHRM volume was performed using machine learning's image segmentation algorithm. This algorithm was trained on SDOCT images from the AVENUE trial and demonstrated excellent correlation with human reading center annotation, as indicated by sensitivity of 84.1%, specificity of 99.8%, and a DICE score of 0.84. In this analysis, we used the algorithm to evaluate both SHRM volume and en-face area in the 3 mm diameter ETDRS subfield in patients from Tenaya Lucerne, who had baseline spectralis SD-OCT images. On the top of this slide is an example SD-OCT B-scan image without SHRM segmentation, while immediately below is the same image with SHRM segmentation. To the right is the en-face view showing SHRM segmentation. As shown here, faricimab resulted in a greater decrease in SHRM volume at weeks 8 and 12 in the head-to-head dosing phase compared with aflibercept 2 mg in Tenaya Lucerne patients with a spectralis OCT image at baseline. Similarly, as shown on this slide, faricimab resulted in a greater decrease in SHRM en-face area at weeks 4, 8, and 12 in the head-to-head dosing phase compared with aflibercept 2 mg. In conclusion, this presentation has summarized findings from machine learning-based analysis of neovascular AMD biomarkers, demonstrating reductions with faricimab compared with aflibercept 2 mg in Tenaya and Lucerne. Specifically, reductions in PED volume, SHRM volume, and SHRM en-face area favored faricimab versus aflibercept 2 mg during head-to-head dosing. Taken together, the neovascular AMD biomarker results show that improvements in PED and SHRM outcomes are consistent with improvements in retinal fluid with a dual Ang-2 VEGF-A inhibitor faricimab versus aflibercept 2 mg. I would like to finish by thanking you and encouraging you to stay online for Jemicheng Salween PCV trial presentation later in the session, which will include results from a biomarker associated with PCV, polypoid lesion.
Great talk as always, Mark. And I think let's march right into Carl Danzig's talk about 4-year outcomes of faricimab and neovascular AMD, safety and efficacy results from Avenel X long-term extension trial. Go ahead, Carl.
Hi, I'm Dr. Carl Danzig. I'm delighted to present 4-year outcomes of faricimab and neovascular AMD, safety and efficacy results from the Avenel X long-term extension trial. Here are my financial disclosures. We learned from the Tenaya Lucerne trials that faricimab was non-inferior to aflibercept 2 mg for functional outcomes while achieving extended durability out to 16 weeks. Patients who completed either of the 2 phase 3 trials without discontinuation of study treatment were eligible to enroll in the long-term extension study Avenel X. The duration of Avenel X was 2 years for total, combined with Tenaya Lucerne, of 4 years follow-up. The primary objective was to evaluate the long-term ocular and systemic safety and tolerability of faricimab and explore efficacy. Eligible patients had monthly mass visits for the first 3 months, followed by an open-label treat and extend period in which patients were required only to attend study visits, at which faricimab was to be administered at intervals determined according to personalized treatment interval algorithm. Of note, when patients transferred over to Avenel X from Tenaya Lucerne, there was no reloading for the aflibercept patients in the parent study. And this has correlation to real-world applications. As you can see here, the treat and extend algorithm is listed on the right-hand side of the slide. Avenel X is the largest extension study in neovascular AMD conducted to date and included 1,029 patients who completed the Tenaya or Lucerne trial. Overall patient retention at Avenel X was high, with more than 85% of patients completing 2 years of treatment. Rates of treatment discontinuation were low, and reasons for treatment discontinuation were unremarkable. BCVA remained largely stable over 2 years with faricimab treating extended dosing in Avenal X. This stability was achieved with a median of 7 faricimab injections during the 2 years of Avenal X. Among patients who had greater than or equal to 20/40 vision at year 1 in Tenaya Lucerne, approximately 75% of patients maintained greater than or equal to 20/40 vision at year 4, the end of Avenal X. Improvement in CST achieved in Tenaya Lucerne were maintained in Avenal X. CST after 4 years was 192.7 micrometers in the patients who were switched from aflibercept 2 milligrams and 193.8 micrometers in the patients who continued on faricimab treat and extend. The durability achieved with faricimab at the end of Tenaya Lucerne, approximately 80% of patients on extended dosing, was sustained at Avenal X, with nearly 80% of patients on extended Q12-week or Q16-week dosing at years 3 and 4. The overall proportion of patients on Q16-week dosing at the end of 4 years was 64%. We conducted an analysis to determine what proportion of patients who completed a Q16-week interval met the extension criteria and could have hypothetically extended to Q20 weeks at the end of years 3 and 4. As shown here, more than 50% of patients met the criteria for potential Q20 week dosing at the end of years 3 and 4. In another analysis, we evaluated fluid resolution at years 3 and 4 among aflibercept 2 milligram poor responders. These were defined as patients with persistent retinal fluid on aflibercept 2 milligram at year 2. Persistent retinal fluid was defined as the presence of intraretinal fluid or subretinal fluid at both weeks 104 and 112 of Tenaya Lucerne. This included 152 patients, or approximately 30% of aflibercept patients who rolled over into Avenal X. After switching to faricimab, 27% of patients with available data had experienced retinal fluid resolution at year 3. By year 4, this proportion of patients was further increased to 44%. Faricimab was well tolerated through 2 years of Avenal X, with the nature of adverse events consistent with the Tenaya Lucerne trials. There were no new safety signals. Ocular AEs were in line with the known safety profile of faricimab or as anticipated by the disease under study. Overall, rates of ocular SAEs were low, and events are in line with known safety profile of faricimab or as anticipated by the disease under study. Overall, rates of ocular adverse events of special interest were low, with 2.8 to 4.2% of patients having any event. Rates of intraocular inflammation, IOI, were low, 1.5 to 2.6%, and there were no cases of retinal vasculitis nor retina occlusive vasculitis. There was no difference in safety profile among patients who switched from aflibercept to faricimab. In summary, Avenal X demonstrated the long-term safety and efficacy of dual Ang2 VEGF-A inhibition with faricimab in patients with neovascular AMD over 4 years. Avenal X is the largest NAMD study to date and had excellent patient retention. Disease control and durability achieved in Tenaya Lucerne were sustained through Avenal X. Furthermore, we saw anatomic benefit when aflibercept 2 milligram poor responders were switched to faricimab. Faricimab was well tolerated with a safety profile consistent with the Tenaya and Lucerne trials. Thank you to all Avenal X investigators and study patients.
Great call. I'll open up to the panel or to my co-moderators. Any questions coming up on the chat or otherwise for the last 2 talks?
Carl, is this a great talk? Is this what you've seen in clinical practice when you get beyond that 2-year mark in patients? Have you stretched patients out that far in your experience? And what do you do when you get to these super long intervals? Do you bring patients in a little bit sooner just to get an OCT? How do you manage it?
That's a great question, Nico. And what we need to understand is that the trial design was supposed to emulate how we manage patients in the real world. But it's still a trial, and how we manage patients on an individual basis is different than a trial. So in some patients that we're going every 4 months, if I get them out there, I will tell them to come back every 4 months. The other thing it allows is that some patients may have GA in the fellow eye. So you may be seeing these patients more frequently than every 4 months because they have a treatment in the fellow eye. Furthermore, what I really liked about like this study in terms of real world application, Nico, is, going from the end of Tenaya Lucerne into Avenel X, there was no reloading. So much like we saw in the Truckee study where there was no reloading, here also there was no reloading. Even in those tough to treat patients that ended with the aflibercept arm, with those 44% patients, they were not reloaded with monthly faricimab like we saw in the beginning of the Tenaya Lucerne study. So I think this is a really important application from the study design, to show what real world, can achieve.
Do we have a second for Dr. Lowenstein, or should we move on?
Whatever.
Sorry,
No,
Dr. Lowenstein. I think
Not
unfortunately we're only
Okay.
half an hour behind right now. I'm trying to
No
claw
problem.
back every
No
30
problem.
seconds spot. Okay, so let's go forward to the next talk to Dr. Viril Sheth, who's going to be speaking to us on the global real world data with faricimab in neovascular AMD and DME, the Voyager study. Thanks, Viril.
Thank you to Phil and the committee for the opportunity to present this data here today. Here are my financial disclosures. Despite strong efficacy in clinical trials, real-world anti-VEGF outcomes often don't match what we see in these trials. This can be driven by several factors. In routine clinical practice, we see far more heterogeneity in our patient populations than those enrolled in clinical trials. Patients differ in disease severity, comorbidities, and access to anti-VEGF therapies, which can significantly influence outcomes. In addition, clinical trials provide limited long-term data, making it challenging to inform treatment strategies beyond the trial horizon. Many of the complex treatment algorithms and intensive imaging protocols that we use in these trials are also difficult to replicate in everyday practice. Finally, there's inherent variation in clinical assessments and management decisions among us as healthcare providers, reflecting differences in experience, resources, and practice settings. So together, these factors highlight the importance of real-world evidence to better understand how therapies perform outside the controlled environment of clinical trials. And these challenges are especially important in chronic diseases like neovascular AMD and diabetic macular edema, where long-term disease control is required. As a result, there's increased focus not just on efficacy, but also on durability and treatment burden reduction in real-world practice. Faricimab represents a novel therapeutic approach. It's the first bispecific antibody designed for intraocular use. It independently binds VEGF-A and angiopoietin-2. VEGF-A inhibition reduces vascular leakage and neovascularization, while Ang-2 inhibition promotes vascular stability and may reduce inflammation. This dual pathway design was developed to support both strong disease control and improved durability. To date, we've seen more than 11 million doses of faricimab distributed globally, which has given us a chance to study its impact in large real-world patient populations. In the pivotal phase 3 trials Tenaya and Lucerne for wet AMD, faricimab demonstrated robust visual gains at year 1 that were maintained through year 2. These outcomes were achieved using treat and extend dosing strategies similar to what we do in the real world. By the end of the second year, approximately 80% of faricimab treated patients were maintained on dosing intervals of 12 weeks or longer, and 63% at 16-week intervals. From an anatomic standpoint, central subfield thickness was reduced early and maintained through 2 years. For the phase 3 DME trials, Yosemite and Rhine, we again see robust vision gains and CST reductions at year 1 that were maintained through year 2. And again, here we see around 80% of patients achieving Q12-week or greater dosing interval. Given the wide adoption of faricimab and our community's proactive nature of collecting real-world data, we see that faricimab is supported by one of the most extensive real-world evidence programs in retina. This includes over 200,000 patients across 38 countries. Here we see prospective studies, registry-based analyses, EMR-based studies, and more than 100 independent publications. Special shout out to Arshad and our Truckee colleagues on the call today for providing some of the earliest real-world data and continued insights into their cohort of patients. Together, all of this provides a comprehensive view of faricimab in clinical practice. We've seen a number of high-quality papers come out in the past few years. Here you see a few examples. And so that brings us to the Voyager study. Voyager is a prospective, non-interventional, multi-country real-world study. It evaluates faricimab as used in routine clinical practice. Voyager includes over 5,000 patients across 28 countries, making it one of the most geographically diverse retina studies to date. Voyager captures outcomes as part of standard of care. There are no mandated visit schedules or treatment protocols. Primary endpoint is change in visual acuity at 12 months, and additional endpoints include anatomic outcomes, treatment patterns, and safety. Here you can see some of the baseline characteristics of the wet AMD Voyager cohort. There was a large representation of treatment-naive patients from Europe, reflecting regional differences in treatment patterns and access. Among previously treated eyes, patients had received a mean of 3.6 years of anti-VEGF therapy prior to initiating faricimab. Notably, 72% of patients had previously been treated with aflibercept 2 mg. Turning now to treatment-naive wet AMD eyes, visual acuity improved following faricimab initiation by an average of 3.6 letters at month 12. This relatively modest gain is likely related to the high baseline visual acuity in this cohort, which was higher than that observed in the registration clinical trials and in other real-world faricimab studies. From an anatomic standpoint, central subfield thickness decreased by approximately 104 microns. In addition, the percentage of eyes with investigator-reported intraretinal or subretinal fluid was lower at month 12 compared with baseline. Finally, the mean number of faricimab injections decreased over the first year from 4.6 injections in months 1 through 6 to 2.5 injections in months 7 through 12. This reduction suggests successful treatment extension during that first year of therapy. Now looking at previously treated eyes, visual acuity and CST remained stable following faricimab initiation through month 12. In addition, the percentage of eyes with investigator-reported intraretinal or subretinal fluid was lower at month 12 compared with baseline. And finally, again, the mean number of faricimab injections decreased by approximately 27% over the first year of treatment, from 4.5 injections in months 1 through 6 to 3.3 injections in months 7 through 12, suggesting, again, successful treatment extension during the first year of therapy. Here we see demographics for the DME-treated patients. Of note, approximately half of the patients were of white descent. Among previously treated eyes, patients had received a mean of 3.3 years of anti-VEGF therapy prior to initiating faricimab, and 58% of patients had previously been treated with aflibercept 2 mg. For treatment-naive DME eyes, visual acuity improved by an average of 5.9 letters at month 12, and CST decreased by approximately 171 microns. In addition, the percentage of eyes with investigator-reported intraretinal or subretinal fluid was lower at month 12 compared with baseline. And finally, the mean number of faricimab injections here decreased by 50% over the first year of treatment, from 4.6 injections in months 1 through 6 to 2.3 injections in months 7 through 12, again, seeing that successful extension during that first year of therapy. In previously treated DME patients, visual acuity and CST remained pretty stable through month 12 of faricimab treatment. Percentage of eyes, again, with investigator-reported IRF or SRF was lower at month 12 compared to baseline. And here we saw the number of injections drop from 4.5 injections in months 1 through 6 to 3 injections in months 7 through 12. From a safety standpoint, rates of intraocular inflammation and endophthalmitis were low when assessed per injection, and these rates were consistent with those observed in clinical trials. So in summary, across clinical trials and real-world studies, faricimab demonstrates consistent effectiveness, durability, and safety in both neovascular AMD and DME. The Voyager study extends these findings to a truly global real-world population and will continue to generate increasingly granular data over time, including future analyses that will leverage imaging data. Taken together, these data support faricimab as a durable treatment option in routine retina practice worldwide. Thank you for your attention today.
Great. I think let's pool these two faricimab talks together again. So let's move on to Gemi-Chung Chu-Ming's talk on faricimab for polypoidal choroidal vasculopathy.
Thank you for the opportunity to present on behalf of the VII investigators the results of this one-year study. These are my disclosures. VII is a phase 3b for multi-center open-label single-arm study designed to evaluate the efficacy, safety, and durability of faricimab in PCV in Asia. In total, 135 patients across 9 regions and 38 sites had been recruited. You can see the geographic distribution in the central panel. In terms of baseline characteristics, the mean age is 68.6 years, with a male predominance of 63%, and in terms of ethnic distribution, majority being Chinese, followed closely by Koreans, Japanese, and other Asian ethnicities. The study design is adapted from the Tenaya and Lucerne trial design, starting off with 4 initial monthly loading doses, followed by a period of disease activity assessment based on CST or BCVA or macular hemorrhage criteria. And if patients did not demonstrate any disease activities, they will be redosed at Q16 until primary endpoint assessment. And those participants who demonstrate disease activity earlier will be redosed at either Q12 or Q8 as shown in this design. At the primary endpoint will be assessed as BCVA change from baseline to the average at weeks 40, 44, and 48. More than 90% of patients completed treatment through week 48, and the 9 participants who discontinued treatment, the reasons are shown in this slide. In terms of other baseline ocular characteristics, I'd just like to highlight that the mean BCVA was relatively high for an Asian trial at 64.4 letters, and the CST started at 417 micron. This is the primary endpoint. You can see that there is robust BCVA increase from baseline through week 48. By week 16, after the 4 loading doses, there had already been a 7.7 letters gain, and this continued during the second phase between week 16 and week 48 with a mean gain at the primary endpoint assessment of 8.9 letters. This graph shows the patients with BCVA of 69 letters or above, and you can see this increased again steadily through the first 4 visits and was very well maintained through to week 48 at 77.2%. The flip side of that shows you the low proportion of patients with poor vision of 38 letters or worse, showing on average less than 5% and a numerical reduction at week 48 compared to baseline. The visual acuity changes are mirrored very nicely with clinically relevant reductions in central subfield thickness from baseline through week 48 with an average of reduction of 126 microns. This graph shows the percentage of patients with absence of IRF or SRF. Again, you can see a steady increase with each of the first 4 loading injections with very minimal fluctuation through the rest of the study period. And at week 48, 76.4% of eyes showed absence of fluid. In terms of choroidal thickness, we also observed a reduction from baseline through to week 48. In terms of polypoidal lesions outcome, on the left you can see the ICGA grading by week 16. The complete polyp lesion closure was 51%. What I thought was very amazing is that between week 16 to week 48, there was fewer injections, and yet we continue to see a further rise in the proportion with polypoidal lesion regression, ending at 61% at week 48. On the right-hand side, this includes both ICGA and OCT findings, and we saw that 86% of eyes had inactivated polypoidal lesions, both at week 16 or week 48. Here, inactivated lesions means either absence on ICGA, or if they are present on ICGA, they did not show fluid on OCT and other assessments. We saw a high rate of polypoidal lesion regression in the VII study, while comparisons across trials should always be taken with a caveat. we observe here that the 61% is one of the highest reported amongst monotherapy arms in previously published trials. Here are a few cases from my site. You can see 4 cases at baseline and week 48. The first 2 cases showed complete regression on ICGA and dry retina, and all of these cases showed increase in the visual acuity. Case 4 showed some persistence in activity, whereas case 3 showed a dry retina but partial closure on ICGA. At the end of week 48, all the participants continued into the second year of the trial, but now following a more flexible treat and extend protocol in which faricimab could be dosed between Q8 weeks to Q20 weeks. And with this design, we saw that at this time point, at week 48, that 50% of patients were assigned to faricimab Q20 weeks in the second year. Here we show a safety profile which is in keeping with previous reports. Here, particularly in terms of intraocular inflammation, there were a few cases with mild inflammation. There was one case reported by investigator as retinal occlusive vasculitis, but when this case was independently reviewed by reading center, that was not actually confirmed. In terms of RPE tear, we also saw a very low number at 1 only. So in summary, faricimab in PCV in the VII study demonstrated robust disease and anatomic improvements through week 48. In terms of BCVA, gaining 8.9 letters. In terms of anatomy, complete regression in 61% and inactivation in 86%, and a large proportion could be extended up to Q20 weeks at the end of week 48, which suggests that the dual Ang2 VEGF-A inhibition with faricimab may constitute good control as well as vascular stabilization. I'd like to finally thank all the investigators and participants at all the sites of the study, and thank you for the opportunity to share.
2 great talks. I'd like to open things up to my co-moderators if there are any questions in the chat or questions that you might have.
I see Dr. Campojaro has a question or comment.
Yeah, thanks. I have a question for Real regarding the Voyager study. It seems like there was quite a bit of tolerance for macular fluid, both with neovascular AMD and DME. And I'm wondering, what the implications of that are. Were patients extended despite fluid, and what are the implications in terms of long-term outcomes?
Yeah, Peter, it's a great observation. I think, there's no protocol here, right? So it's really just kind of following what people are doing in the real world. And so I think the answer to your question, I don't know the answer to your question just yet, but I do think that as we get imaging data, which is kind of next on the agenda, we'll kind of really get to dive into what's happening, at the site level. Maybe, it's different based on what country you're practicing in. You saw this data has a lot of European data. And so, you wonder if there's just different practice patterns. I think that's what's going to be more clear as we get bigger ends. So this set, I think, was about 1,000 patients. There's going to be 5,000 patients when all is said and done. I think we're going to learn a lot more after that.
Thanks.
Great. So I think with that, let's go on to Dante Pieramici, the Pagoda trial, year 4 results.
Dr. Dante Pieramici, and today I am pleased to be presenting at Angiogenesis 2026 Pagoda trial results through year 4, port delivery platform with ranibizumab for the treatment of diabetic macular edema. These are our financial disclosures. Genentech Roche supported this research. The port delivery platform is an innovative drug delivery system for the treatment of retinal diseases. With ranibizumab, the PDS is approved in the United States for the treatment of neovascular AMD, diabetic macular edema, and diabetic retinopathy. The PDS is an intraocular implant surgically placed at the pars plana. With its continuous drug delivery, refill exchanges are needed every 6 to 9 months for sustained durability. In Pagoda, patients with center-involved DME were randomized 3-2 to treatment with PDS at fixed refill exchanges every 24 weeks or to monthly intravitreal ranibizumab 0.5 milligram injections. PDS patients were scheduled to have implantation at week 16 or 20, after which they received refill exchanges every 24 weeks. Patients randomized to the intravitreal arm had the option to switch to PDS at 64 weeks. Both arms underwent a refill exchange procedure Q24 weeks thereafter for the remainder of the study. Pagoda met its primary endpoint with the PDS Q24-week refills being non-inferior to monthly intravitreal injections. Week 208 is 4 years post-implantation for the PDS arm and 3 years post-implantation for the intravitreal PDS arm. Efficacy analyses are based on the adjusted intention-to-treat population of both arms. In the PDS arm, this includes patients randomized to PDS treatment who received an implant at week 16 or 20. In the intravitreal to PDS arm, this includes patients randomized to intravitreal ranibizumab treatment who received an implant at week 64 or 68. This excludes patients with delayed implantations, delays due to COVID in the PDS arm and voluntary recall in the crossover arm. Safety analysis were performed on all patients receiving an implant. 77% of all patients completed the study through 4 years. The rates of discontinuation were similar in both arms, with the most common reasons being death, loss to follow-up, and withdrawal by patient. Patients treated with PDS Q24 weeks maintained vision gains from week 64, increasing 8.6 letters from baseline at week 208. Patients treated with Q4 intravitreal injections were implanted at week 64 or 68 and maintained vision after the switch to 7.1 letters from baseline. In both arms, there is a transient and expected decrease in vision during the postoperative period following PDS implantation. After vision recovery, there was a trend to continued improvement in comparable BCVA seen in both arms. There was a sustained decrease in central subfield thickness through week 208 in both arms. At week 208, CST changes from baseline were minus 207 micrometers and minus 212 micrometers in the PDS Q24 week and the intravitreal to PDS arms respectively. Intravitreal to PDS maintained CST improvements following the switch. There was also a sustained proportion of patients with a 2 or more step improvement from baseline in DRSS through week 112 in both arms. At week 208, the proportion of patients with 2 or more step improvement from baseline on DRSS was 43.5% and 45.1% in the PDS Q24 week and the intravitreal to PDS arms, respectively. Intravitreal to PDS patients maintained DRSS improvement following the switch. Supplemental treatment was assessed at the 2 visits prior to each refill exchange and was based on worsening disease, vision, CST, or the development of PDR. Through 8 refill exchange intervals in the PDS arm and 8 intervals in the crossover arm, approximately 95% of the PDS Q24 week did not receive supplemental treatment within each refill interval. Ocular adverse events of special interest were well understood and manageable through week 208. No new safety signals were reported. 6 cases of endophthalmitis were reported for an incidence of 1.1%. When we consider the incidence of endophthalmitis in Pagoda at week 208, it is worth considering the projected incidence that would be expected if intravitreal injections were given. AAO's 2025 intravitreal injection policy cites 2 meta-analyses and reports an incidence of endophthalmitis of approximately 0.05% per intravitreal injection. In Pagoda, the observed incidence of endophthalmitis was 1.1%, with 6 cases occurring with 3.43 years mean duration of PDS treatment. If the same patients receive intravitreal injections over the same duration of time, assuming an incidence of 0.05% per injection, the projected incidence of endophthalmitis in the injection-treated eyes would be 1.1% for injections given every 8 weeks and 1.7% for injections given every 6 weeks. In this case of a study patient with bilateral diabetic macular edema, we see the spectral domain OCT images of the study and fellow eye over 208 weeks of a 49-year-old male patient. In the PDS study eye, he received 4 loading doses and was implanted at week 16, after which he received 8 refill exchanges. In the fellow eye, he received 27 injections. Over 4 years, both eyes achieved good control of DME and DR, but the injection eye received twice the number of treatments. This 4-year analysis of the Pagoda Phase 3 trial shows that patients implanted with PDS in year 1 made robust vision, CST, and DRSS gains that were maintained through 4 years. Vision and anatomical outcomes at 4 years in the crossover patients who received an average of 16 intravitreal ranibizumab injections prior to receiving the PDS were consistent with those who received PDS after 4 injections. Through each refill exchange interval, 6-month durability was achieved in 95% of all patients, with 5% of patients receiving supplemental treatment. The safety profile at 4 years of follow-up remains consistent with the primary analysis and the overall safety profile of PDS, with no new safety signals observed. In summary, continuous anti-VEGF delivery via the PDS has the potential to transform the care of patients with DME by preserving vision while reducing treatment burden. Special thanks to all the Pagoda investigators, the research teams, and the patients who took part in the studies, and thank you to the organizers for including us in Angiogenesis 2026.
Great talk by Dante, as always. Unfortunately, Dr. Pieramici was not able to be with us this evening. So I think, again, in the interest of trying to catch up, let's move ahead to Dr. Campochiaro's talk on the suppression of VEGF-A being sufficient to effectively treat 95% of DME patients. Can't wait to hear this talk. Thank you, Dr. Campochiaro.
I'd like to thank Phil, Harry, and Tom for allowing me to provide this patient-level post-hoc analysis from the Pagoda clinical trial. I'd like to recognize Anna Rustum for her major contributions to the study. These are my disclosures. I'm on an advisory board for Genentech, for which my institution receives payment. Clinical trials in DME have shown that frequent anti-VEGF injections cause substantial improvements from baseline mean best-corrected visual acuity. Is this because there's a subgroup of patients who are particularly responsive and then others who are unresponsive? That's the impression of many retina specialists, because it's often stated that up to 40% of DME patients are unresponsive to anti-VEGF-A injections. If that's true, it has important implications, because it motivates early switching to faricimab or steroids and development of new agents targeting other pathways. The PDS is a reliable way to assess responsiveness to VEGF-A suppression because it provides high levels of ranibizumab to the retina at all times. This red line in this graph shows the vitreous ranibizumab levels throughout 2 refill exchange periods, and the levels never drop below 10 micrograms per mil, which is quite high. In fact, it's sufficiently high that it should continuously block VEGF-A in most DME patients. 57 PDS patients from 8 Pagoda sites had each OCT from every study visit analyzed to determine response to VEGF suppression over time. And the mean follow-up was 159 weeks, which is about 3 years. Some patients with severe edema had a rapid response. This one showed elimination of edema through the run-in period and then never had recurrent exudation. However, other patients had a very different course. This patient had very severe edema at baseline with a CST of 605 microns and continued to have severe edema at the time of PDS implantation. On these composites, the first in circle 100 represents PDS implantation, and each subsequent one is a refill exchange. This patient had persistent subretinal fluid and a large cystoid space for more than a year after treatment initiation. In clinical practice, this patient would have been labeled as VEGF-A treatment unresponsive and probably would have been switched to faricimab or a dexamethasone implant. However, with continued VEGF-A suppression, eventually the edema improved, and at last follow-up, there was no central edema and 20/20 vision. This patient showed a large cystoid space that slowly resolved, and at last follow-up had no edema and 20/20 vision. And I'm going to show a few of these composites just to show the consistency of this observation. Here again, severe edema, large cystoid spaces, gradually resolved, and at last follow-up, no edema and 20/20 vision. And this patient had even more persistent cystoid space, but did gradually resolve, and at last follow-up, vision was good with 20/25 or 20/32-2 vision. And this patient had very persistent cystoid space, and at last follow-up still had a small amount of intraretinal fluid, but 20/16 vision. And even patients with somewhat less severe DME at baseline had this pattern and this one had a smaller cystoid space, a CST of 376 microns, but it was quite persistent, but ultimately did resolve with 20/25 vision and no edema at last follow-up. Now the far right column in this table shows the time course of edema elimination in the 57 patients. Less than 50% showed elimination of edema at 3 months, and about 50% showed elimination of edema at 6 months. But with continued VEGF-A suppression, ultimately 96% had resolution of edema. And at last follow-up, only 2 patients had uncontrolled edema. One initially had a good response, but then escaped from VEGF suppression, and one never showed good control of edema. This is the patient who had an initial good response with resolution of edema, but had recurrent edema that gradually worsened over time, and at last follow-up had severe edema, but even so had 20/32-2 vision. And this is the patient the only patient in our 57 patients who could legitimately be labeled as VEGF-A suppression unresponsive, because this patient had a large cystoid space that never changed very much, and at last follow-up was still present, but even so, vision was 20/40. Now, how representative are these 57 patients to the full cohort of PDS patients in the Pagoda trial? Well, they're very representative. The change in CST, mean CST over time, in the 57 patients shown in red is identical to the full PDS cohort shown in blue. And this spaghetti plot shows that all Pagoda PDS patients with a baseline CST greater than 600 were responsive to VEGF-A suppression. They all showed reduction in CST over time, some very rapidly, some more slowly, but all clearly responsive to VEGF-A suppression. And then 3 showed this phenomenon of escape. All of the PDS patients with a screening CST between 550 and 600 microns showed improvement in CST over time. Once again, some quite rapidly, others more slowly, but clearly all responsive to VEGF-A suppression. And all of the PDS patients with a starting CST between 500 and 550 microns showed similar graph, and all the remaining PDS patients did as well. I just don't have time to show them. This patient-level study indicates that VEGF-A is the main stimulus for DME. In fact, it's the sole stimulus in most patients with DME because selective sustained suppression of VEGF-A is sufficient to eliminate DME in roughly 95%. In some, it may take many months.
And in fact, substantial edema is still present in 50% of DME patients at 6 months. And such patients have been labeled as unresponsive to VEGF-A suppression, but that's incorrect. They're simply slower to show a strong response. And then there's rare patients who show an initial response and then escape from VEGF-A suppression. The mechanism for that is unknown, and it deserves further study. And then finally, visual outcomes are excellent, even in patients with slow resolution of edema. I'd like to acknowledge the investigators at the other participating sites and the investigators from Genentech.
Great work. Again, I'll open it up. Anybody have any questions about the two port delivery talks or comments?
I have
If
a
not,
question.
yep.
We know that from following patients with DME, there's a different natural course in AMD, and some of these patients, as they get better glycemic control, the disease kind of burns out post year 3 or 4, and they don't really need much treatment. So some of the data showed you have a 1% endophthalmitis rate. Some patients are getting retraction erosion. How do you manage patients when you get to that point where you feel that the port's not really needed? Is it feasible to remove it? And would you consider doing so?
Nico, that's a great question. I wouldn't remove the port. I think that the reason for long-term for late endophthalmitis is related to refill exchanges. So if you were concerned about that, you just would leave the port and just not do refill exchanges. But I think the incidence of endophthalmitis is very low. And the other benefit in these patients is that you essentially eliminate vision-threatening complications. And we know that although it's stated that patients kind of burn out or anything, many of those patients who follow them along, they have recurrence of edema. So I think it's a good strategy to continue long-term VEGF-A suppression.
Just to clarify, those patients that you showed that had the recurrence, months and months into the trial, they were getting full port delivery refill and had active anti-VEGF-A going on at the time of the recurrence. Is that true?
Yes. So some of the ones that I showed, yes, that's the case, Tom. There were patients who had stopped treatment or something, but at least a small percentage. It's only, a few percent that have this escape phenomenon. But it's an interesting phenomenon that we need to study more.
And it's not as easy as the hemoglobin A1C went up.
So,
or blood
no,
pressure went up.
It's not that. It's not that. But it could be, there are two main things. It could be that they have suddenly increased expression of VEGF-A, or it could be that they're producing other permeability factors. And there's sort of, hints going both ways, but we don't know the final answer yet.
Great. Thank you very much. Okay, with that, we'll move on to Dave Brown, who'll be telling us about high dose aflibercept in patients with neovascular AMD or DME, the primary results from phase 3b ELARA trial. Thank you, David.
Hello, I'm Dave Brown. On behalf of my ELARA co-investigators, pleased to present the primary results from the phase 3b ELARA trial. Here are my disclosures. Key takeaways are aflibercept 8 milligram every 4 weeks achieved functional and anatomic improvements at week 24 in patients previously treated with anti-VEGF agents for neovascular AMD or DME. Here you see a mean increase of 2.5 letters in the neovascular AMD arm and 3.2 letters in the DME arm. Safety profile of aflibercept 8 milligram monthly, consistent with the safety profile of previously published aflibercept 2 milligram and 8 milligram at differing dosing. There was no clinically relevant change in pre-dose intraocular pressure. The incidence of hypertension deaths and deaths was low and consistent with that of prior aflibercept trials. Aflibercept 8 milligram in treatment-naive patients has been demonstrated at extending dosing intervals to improve best-corrected visual acuity and central retinal thickness, comparable to aflibercept 2 milligrams every 8 weeks, in the 2-year pivotal trials for neovascular AMD, Pulsar, and DME Photon. However, as these trials were both treatment naive, the efficacy and safety of aflibercept 8 mg every 4 weeks is unknown, as well as whether aflibercept 8 mg can improve outcomes in patients who have previously received anti-VEGF treatment for neovascular AMD or DME. The ALARA trial evaluates the safety and efficacy of monthly dosing with aflibercept 8 mg in previously treated patients with neovascular AMD and DME. The ALARA study design was conducted across 53 U.S. sites. Large study, 1,110 patients. They all had to have had at least 3 anti-VEGF injections within the 5 months prior to study start. We then treated with 8 mg injections every 4 weeks and then presenting the 24-week primary endpoint. At this point, there could be dose interval extension, but only like we do it in the clinic, with no retinal fluid before you extend and no relation to visual acuity. In DME, it has to be less than 300 microns or 320 microns on the spectralis and 10 microns increase or less from the previous central subfield thickness. What I'm presenting today, though, is the primary 24-week endpoint. Patient disposition was excellent. Of the 1,110 patients, 1,066 completed the week 24 visit. The most common cause was withdrawal of consent. We had 2 deaths in each arm. At baseline, the mean age was 77.1 years in the neovascular AMD and 62.8 in the DME cohort. We had more female patients in the neovascular AMD compared to the DME cohort. And as you might expect, neovascular AMD was predominantly white patients, whereas the DME had much more diversity. Notably, 2/3 of the patients in each cohort had a history of hypertension at baseline. At baseline, best corrected visual acuity, 68 letters and 69.8 letters, AMD and DME respectively. Half the patients had a baseline visual acuity greater than 73 letters, and the mean baseline thickness was quite a bit thicker in the DME versus the AMD cohort. As I stated, you had to have at least 3 anti-VEGF treatments, and patients had a lot of different drugs. Approximately 32 to 38% had multiple agents. Interestingly, 8% of patients in the AMD and 4% of the DME had received prior 8 mg aflibercept in the 6 months prior to initiation. Number of treatments was quite a bit. 30% of the patients had at least 5 injections before trial initiation. Most of them had 3 to 4 in the previous 6 months. This is our visual acuity outcomes. Mean best corrected visual acuity was 2.5 letters greater at week 24 with a mean of 6 injections. Note that 32.9% gained at least 5 letters. Mean subfield thickness decreased by 27.1 microns in patients with AMD at week 24. The mean best corrected visual acuity in DME was 3.2 letters at week 24. Note that patients received a mean of 5.8 injections. 36.8% of patients gained at least 1 ETDRS letter. In addition, central subfield thickness decreased by 39.7 microns in the patients with DME. Let's look at safety. Through week 24, ocular treatment emergent adverse events, 17% and 22.3% in AMD and DME, respectively. Most common were conjunctival hemorrhage, cataract, and vitreous floaters. Serious adverse events was low in each cohort. Most common was endophthalmitis, with 3 cases in diabetic macular edema. Note we had 1 case of retinal detachment in the AMD cohort and 1 case of retinal vasculitis in the DME cohort. Intraocular inflammation was reported in 1% of each cohort through week 24. Intraocular pressure was reported low proportions of patients with neovascular AMD and DME throughout week 24. And furthermore, no clinically relevant change was observed in pre-dose intraocular pressure through week 24. Serious non-ocular treatment adverse events reported in 5% of the AMD cohort and 7.2% of the DME cohort. Most common was cerebrovascular accident and myocardial infarction. Note we had 2 patients that died in the AMD cohort and 4 patients in the DME cohort through week 24. In conclusion, 8 milligram of aflibercept every 4 weeks achieved functional and anatomic improvements at week 24 in patients previously treated with anti-VEGF agents for either AMD or DME. Safety profile was consistent with the established safety profile of both the aflibercept 2 milligram and 8 milligram. No change in relevant pre-dose intraocular pressure over time, and the incidence of hypertension events and death was low and consistent with that of prior aflibercept trials. The ALARA is ongoing, and all patients will have the opportunity to achieve extended dosing intervals based on the DRM I showed. We look forward to sharing the data with you soon.
I'm going to group the next the 3 high-dose aflibercept talks together, and then we'll talk about them. And with that, I'll invite Varun Chaudhry to give us his talk on high-dose aflibercept macular edema following retinal vein occlusion, the QUASAR study.
I'm Varun Chaudhry, and on behalf of my co-investigators, I'm presenting the week 64 results for QUASAR, the first phase 3 study to assess intravitreal aflibercept 8 milligrams in patients with treatment-naive macular edema secondary to retinal vein occlusion. Here are my disclosures. The QUASAR study design is summarized showing 3 aflibercept treatment arms and associated dosing schedules. QUASAR was a 64-week, multi-centered, randomized, double-masked phase 3 study in patients with treatment-naive macular edema secondary to retinal vein occlusion. Patients were randomized in a 1:1:1 ratio into 3 treatment arms: aflibercept 2 milligrams every 4 weeks, aflibercept 8 milligrams every 8 weeks after 3 initial monthly doses, or aflibercept 8 milligrams every 8 weeks after 5 initial monthly doses. Dose regimen modification criteria were applied at specific time points for each treatment arm to shorten or extend intervals between injections. Of note is the treatment regimen with aflibercept 8 milligrams enables extension of dosing intervals relatively early in the course of treatment, which differs from other pivotal trials of anti-VEGF for RVO. The primary efficacy endpoint changed from baseline in BCVA at week 36, with a non-inferiority margin of 4 letters was met. The key secondary efficacy endpoint was number of active injections from baseline to week 64. At week 64, other secondary endpoints included change from baseline in BCVA and CRT, durability, and safety. The baseline demographics and disease characteristics were balanced between the 3 treatment arms. Overall, the mean age was 66 years and 48% of patients were female, with a baseline BCVA of approximately 55 letters. A balanced distribution of BRVO and CRVO HRVO subtypes were included in each treatment arm. The primary endpoint of non-inferiority compared to monthly aflibercept 2 milligrams was met at week 36. Both aflibercept 8 milligram arms achieved rapid and sustained BCVA gains with fewer injections compared with 2 milligrams. The 8 milligram arm with 3 monthly loading dose had a mean number of active injections of 6.1, while patients in the 2 milligram arm received 8.8 injections. Improvements in BCVA achieved at week 36 were maintained through week 64 across all study arms. Both aflibercept 8 mg arms achieved rapid and sustained BCVA gains. The key secondary endpoint was a comparison of the number of active injections between the aflibercept 8 mg and 2 mg arms at week 64. The aflibercept 8 mg arms received significantly fewer active injections in comparison to 2 mg, with a mean of 8.5 and 9.5 for the 8 mg with 3 monthly loading doses and 5 monthly loading doses respectively, compared with 11.7 for the 2 mg monthly dosing arm. The observed reduction to CRT achieved at week 36 was maintained through week 64 and comparable for aflibercept 8 mg and 2 mg. Similar to the visual acuity gains, anatomic improvements were achieved early in the course of treatment with significantly fewer active injections for aflibercept 8 mg compared with 2 mg. At week 64, 66% of patients in the aflibercept 2 mg group and 73.8% of patients in the pooled 8 mg groups were fluid-free in the central subfield. Shown here is the proportion of patients with the last completed dosing interval of Q4 at week 64. Although all patients could have had the dosing intervals extended, roughly 3 times fewer patients in the aflibercept 8 mg groups completed the study on a Q4 dosing interval versus those in the 2 mg group. At week 64, the majority, approximately 80% of aflibercept 8 mg treated patients completed dosing intervals of at least every 12 weeks. Roughly 3 times fewer patients needed to stay on every 4-week intervals with aflibercept 8 mg compared with aflibercept 2 mg. In the 8 mg arm with 3 monthly loading doses, 40.5% of patients had a last assigned dosing interval of Q20. Aflibercept 8 mg demonstrated a safety profile consistent with the established safety profile of aflibercept 2 mg and 8 mg. In summary, improvements in BCVA and CRT achieved at week 36 were maintained through week 64 across all treatment groups with up to 3.2 fewer injections with aflibercept 8 mg compared with aflibercept 2 mg. At week 64, more patients treated with aflibercept 8 mg were fluid-free in the central subfield compared with those on aflibercept 2 mg. Approximately 80% of patients treated with aflibercept 8 mg achieved dosing intervals of equal to or greater than Q12 weeks, with 41% of those in the 8 mg arm with 3 monthly loading doses being assigned to Q20 dosing intervals at week 64. Nearly 3-fold fewer patients required Q4 weeks dosing with aflibercept 8 mg at week 64, despite patients on aflibercept 2 mg having the opportunity to extend dosing intervals. Safety data of aflibercept 8 mg in patients with RVO from Quasar through week 64 were comparable to the known safety profile of aflibercept 2 mg and 8 mg. I would like to thank all the patients and the investigators who took part in the Quasar trial. Thank you.
Thank you very much for that talk. And let's move on to Jack Wells' talk on the pooled safety data for high-dose aflibercept across multiple studies. Take it away.
On behalf of all the investigators and my co-authors, I want to thank Phil, Tom, and Harry for inviting me to share these data at this year's Angiogenesis Extravaganza. These are my disclosures, and I am an investigator for Regeneron. Aflibercept 8 mg has demonstrated comparable safety and efficacy to aflibercept 2 mg in the pivotal Pulsar trial in neovascular AMD, the Photon trial in DME, and the Quasar trial in RVO. In each of these trials, ocular and systemic safety profiles were similar between the 8 mg and 2 mg treatment arms for up to 96 weeks. This pooled analysis of safety data from these 3 trials, plus the phase 2 Candela trial in neovascular AMD, was done to evaluate safety across multiple retinal diseases. Data from 4 multi-center randomized clinical trials comparing the efficacy and safety of 8 milligram versus 2 milligram aflibercept were pooled. The 4 studies were the 44-week phase 2 Candela trial in treatment-naive patients with neovascular AMD, the 96 weeks phase 3 Pulsar trial in treatment-naive patients with neovascular AMD, the 96-week phase 2-3 Photon trial in treatment-naive and previously treated patients with DME, and the 64-week phase 3 Quasar trial of patients with macular edema from retinal vein occlusion. In this analysis, safety data were evaluated from 2,665 patients. Of these patients, 857 were in the 2 milligram group and 1,808 were in the pooled 8 milligram group, which included all aflibercept 8 milligram treatment groups from each trial. Treatment emergent adverse events reported by investigators were coded using the latest version of MedDRA. Reported terms were pooled for the purpose of this analysis, and the data were summarized descriptively. Baseline demographics were similar between the groups with respect to sex, age, and race. The pooled aflibercept 8 milligram and 2 milligram groups received a total of 15,090 and 9,836 aflibercept injections, respectively, through week 96. The mean number of injections was 8.4 in the 8 milligram group and 11.5 in the 2 milligram group, and the mean treatment duration was 78.1 weeks and 75.9 weeks for the 8 milligram and 2 milligram groups, respectively. Rates of ocular adverse events were comparable, with about 45% of patients in the 8 and 2 milligram groups having at least one or more adverse event. The most common being cataract, which occurred in 8.2% of eyes in the 2 milligram group and 9.3% in the 8 milligram group. Serious ocular treatment emergent adverse events occurred in 1.8% of patients in the 2 milligram group and 2.1% in the 8 milligram group, with similarly low rates for a variety of conditions occurring in 2 or more patients in each group. The incidence of intraocular inflammation-related events was low and comparable between the 8 and 2 milligram groups. Most IOI cases were non-serious and mild or moderate in severity. Through week 96, 1 case of endophthalmitis was reported in the 8 milligram group and 5 cases were reported in the 2 milligram group. The proportion of patients with an IOP increase of at least 10 millimeters of mercury from baseline pre-dose at any visit was similar between the 8 and 2 milligram groups across all 4 studies. Similarly, the proportion of patients with an IOP of at least 35 millimeters of mercury pre or post-dose at any visit was comparable between both groups across the trials. The incidence of intraocular pressure and glaucoma-related events was low and comparable between the 8 milligram and 2 milligram groups. The rate of paracentesis procedures was low, with 0.7% of patients in the 8 milligram group and 0.2% of patients in the 2 milligram group requiring paracentesis. The incidence of non-ocular adverse events was comparable, with just over 2/3 of patients in both groups experiencing 1 or more adverse events, the most common being COVID. The incidence of potentially clinically significant blood pressure elevations was low and generally similar in the pooled 8 milligram and 2 milligram groups across all 4 studies. Serious non-ocular adverse events occurred in about 17% of patients in each group, the most common being pneumonia. About 3% of patients in each group experienced one or more APTC events. A limitation of this analysis is that the safety data comes from 4 differently designed trials with different durations of exposure to each aflibercept dose. In conclusion, in this pooled analysis of safety data for 2,665 patients with neovascular AMD, DME, or RVO across 4 clinical trials, the safety profile for aflibercept 8 milligram was comparable to that for aflibercept 2 milligram up to 96 weeks. The incidence of intraocular inflammation was low and comparable. There was 1 case of endophthalmitis in the 8 milligram group and 5 cases in the 2 milligram group. The incidence of intraocular pressure and glaucoma-related adverse events and paracentesis was low and comparable between the 2 groups, as was the incidence of non-ocular adverse events, including serious adverse events, APTC events, and treatment-emergent deaths. Thank you very much for your attention.
Great stuff. Basil, any questions or thoughts?
Yeah, absolutely. So with Dr. Wells kind of showing a similar safety profile between 2 milligram and 8 milligram of aflibercept, I was wondering, both for Dr. Brown and Dr. Chaudhry, how do you think about switching patients from 2 milligrams to 8 milligrams? Are this going to be pretty much patients that you can't extend or are not having a good enough response, or even people with a good response where you want to extend them longer? How do you do that in clinical practice?
The way I look at it, you're just giving 2 extra half-lives. So if you have somebody who really needs drug very often, you will extend them further. You will not get them to 8 weeks, and that's why we had to do this ALARA trial. If you're getting 8 weeks, that means your half-life of aflibercept is probably 10 days or so. So you're getting probably 3-4 weeks in addition. So.
And for my practice, Basil, I mean, obviously some of this is dictated by reimbursement rules and regulations, but certainly I've become much more comfortable with switching 2 milligrams to 8 milligrams. And I actually looked at this retrospectively for about 70 patients I initially did. And essentially in all those patients, whether they were 6 weeks, 8 weeks, 10 weeks, longer extension, I was getting longer extensions. Now this is retrospective clinical practice data, but certainly I did, I feel you could get on patients who on 2 milligram doing well, even when they were stable, I was able to extend them longer. These are patients who would have failed previous extension with 2 milligrams. So small end retrospective, but I was certainly happy with the extensions I received.
Best patients are the ones that you can't dry out on 2 milligrams or can't go 8 weeks on 8 milligrams, or you're giving them all the faricimab in the fridge or 2 milligram. They can't control the 8 milligrams, just more anti-VEGF. So.
I would just say real quickly that, given that the plasma levels of aflibercept after an 8 milligram injection are much higher than you saw with 2 milligram, I think this long-term safety and the 4-week data that Dave showed is reassuring that you don't see an increase in systemic adverse events.
Great. And finally, a uveitis talk. I couldn't be more excited. Sumit Sharma is going to be telling us about a bispecific trap antibody inhibiting interleukin-6 and vascular endothelial growth factor a study in patients with macular edema secondary to inflammation. Let's hear it.
I'd like to thank the organizing committee for the opportunity to present on behalf of the APEX study group the first-time end-of-study results of the Phase 1b APEX study in patients with MESI. My financial disclosures are as listed. KSI 101 is a first-in-class high-strength intravitreal biologic that combines an anti-IL-6 antibody with a VEGF trap molecule. MESI, or macular edema secondary to inflammation, is not a term we've really heard before, but it allows us to combine a heterogeneous group of diseases into one entity, and they are caused by a common underlying pathophysiology, which is inflammation and blood-retinal barrier disruption causing macular edema. And it really is a heterogeneous group of diseases. It includes the traditional uveitis entities, regardless of location, that leads to macular edema, but it also includes things like postoperative macular edema and inflammatory CNV membranes, as shown here. APEX was a phase 1b multiple dose study of patients with MESI who were randomized to one of 3 dose levels to receive 4 monthly injections followed by a 12-week off-treatment observation period. The baseline characteristics are shown here, and because it's a phase 1 study and it's small, there were some imbalances between the groups. But what we saw is across the board an improvement in visual acuity up to 20/25 by week 20. And if we look into it deeper, we see that in the top 2 dose levels, after just a single injection, you get a 10-letter gain by week 4 and almost an average of 13 to 14-letter gain by the end of the study. More than half of the patients overall had a 15-letter gain, with most benefits seen in those top 2 dose levels. And matching that, we see that the OCTs dried nearly completely, and we see that even as early as week 1, you have a massive improvement that's maintained in that off-treatment observation period. And really, most of these patients dried. So after the 4 loading doses, you can see that 96% of the patients have no intraretinal fluid and none of them have any subretinal fluid. And that improvement is maintained in the vast majority of patients in the off-treatment observation period. Overall, in a phase 1 study, safety is paramount, and this was very well tolerated with no episodes of occlusive vasculitis, cataract, or elevated IOP, and only 2 episodes of intraocular inflammation, which were deemed by the treating investigators to be recurrences of the underlying uveitis. Let's look at all of the OCTs across the board, and we see here a massive reduction after just a single dose of KSI 101, and this is pretty dramatic. This is at week 4. Well, what happens in the rest of the patients? We see similar massive improvements in all dose levels after the 4 loading injections. That is then very nicely maintained in the off-treatment observation period. And we haven't seen this level of transparency before really in any study, but here is all of the patients in the study and how they've done. And you can see that this was not just mild levels of inflammation. Many of these patients had significant CME that improved nearly completely across the board with very low rates of recurrence in that 12-week off-treatment observation period. And this is a fantastic result. And based on the positive data from this study, 2 paired phase 3 studies in PEAK and Pinnacle are currently actively enrolling, with patients randomized 1:1:1 to either 5 milligrams, 10 milligrams, or sham, with a primary endpoint of combined mean change in BCVA at week 20 and 24. Thank you.
Great study, impressive results. So I have to admit, I can't help but be a little bit frustrated that I can't tell the difference between the ones that have inflammatory choroidal neovascular membranes and the ones that have inflammatory CME. Is the study going to go on keeping them pooled together? And just wondering whether you think that's a benefit to keep it that way, or are you frustrated similarly to the way I am?
I think it's nice to see them separately, and I think they are going to stay combined when they do the phase 3. However, it is a benefit in terms of being able to treat any of these patients. You have a very broad label once you go, if it gets approved and goes to market. We'll have to see and break down the ones that are true uveitis versus post-surgical versus post-inflammatory CNV later on. But at least we'll get a broader label because of it, potentially.
Are they going to stratify the group so that there's a good number of each of the etiologies in each arm so that we can draw conclusions about the subgroups?
There is a plan for that, yes.
Great. Any other questions or concerns about the talk? No, I guess with that, we're going to close the session. Thank you so much to my co-moderators. Don't forget about the virtual exhibits. Please take the pre-tests. Please send any questions that you have through the chats, and we'll try to answer them even after the sessions are done. Remember that you can reach out and arrange times to meet with people. With that, we'll move on to session number 8, diabetic retinopathy and MACTEL type 2. Thank you.